Okay, let's go ahead and jump on in. Welcome back, everyone, to session 3 of our C-Suite Learning Network on HPET program financial planning. Just a quick reminder, if you have any technical issues with Zoom, please feel free to send a message to Mariah in the chat, or you can email her at mblake@clinicians.org. and she will get you taken care of. But otherwise, everyone knows the drill with Zoom these days. We're going to have a couple of guest speakers, so we'll get to all of them in a moment. So make sure, obviously, when they're speaking, you're on mute, but at the end of both their presentations, they're going to have time for questions. So be sure to be thinking about questions, and at the end, we can moderate that. You can either put your questions into the chat or use the raise hand feature on Zoom, and I'll try to help moderate the questions. As usual, here on behalf of ACU, the Association of Clinicians for the Underserved, and ACU's STAR Center program, our NTAP, funded by the Bureau for Health Workforce. And with us today, we have, I believe, the entire STAR Center team on with us today. So that's really exciting. No pressure on my part. Hopefully I don't mess up. I'm glad I'm not presenting today. But again, running this learning collaborative are myself, Helen, and Mariah. And then now that it looks like everyone is on, we are just going to put you in breakout rooms for a few minutes here. And basically, I just wanted you to have about 5 or 10 minutes to kind of discuss the coursework. And, oh, okay, excellent. And Mariah just messaged me, so we won't even go into breakout rooms. I just wanted to hear if anyone has any thoughts on the coursework from last session. And just a reminder, that was about assessing needs and gaps for building out your HPET program and really digging into the time frame around that. So did that worksheet kind of help with sorting out a time frame? And does that time frame feel realistic, or did you kind of look at that and think like, oh man, maybe we'll need more time, or maybe we can do this faster? What did everyone feel like after completing that coursework?
True confessions, I did not get to.
No worries. And so if you didn't get a chance to complete the coursework, what are kind of your thoughts if you are planning on creating a program? Do you have a current idea of what kind of time frame you're looking at to get it started up and going? Or if you already have a program in operation, what's your timeline for expanding on it or building it out or making whatever modifications you're looking into doing with that program?
Maybe I should be visible here. I'll speak up. Joan Lane, I work at Southwest Community Health Center in Bridgeport, Connecticut, and we have a pretty robust program. And I guess you know, I'm the person who does all the matching and the onboarding, and I'm only here 3 days a week. And frankly, I guess the reason I didn't get to the homework is that I'm kind of swamped in doing the stuff. You know, I think. I don't know that we can realistically, you know, what appeals to me about this program is the idea of trying to be a little more financially astute about how we're doing it, which I know is part of the emphasis. You know, in theory, maybe we'd like to grow it, but there are only a limited number of people who will precept at any given time. So it's hard to do that. But I mean, on the other hand, I shouldn't say that because we're taking on relationships with a couple of new agencies at which we'll host some clinical sessions, and we will expand our program to include the possibility of students, you know, populating those sites as well. So not sure it'll be a lot more providers or students, but additional locations is part of it. But what we really wrestle with on the financial side is some of the schools that we have ongoing regular relationships with do give us a stipend, which we have a stipend program for preceptors. We don't literally take the money from the school and give it to the preceptor. We have just a standardized approach that we take. So whether they give us a little more or a little less, then we pass along. We have standardized it. But some of the schools that approach us don't, and it's been kind of hard to figure out how to deal with that. Right now, we don't pay people to precept if we don't get something from the school. But that's kind of awkward too. So that's my little piece.
Yeah, no, that's really good insight on some of the challenges, I think, of working with partner institutions, and kind of that everyone, partnership is going to come with different ideas of what they want or can provide. And so, yeah, I think that is certainly a real challenge. And if you, over the course of the Learning Collaborative, come up with other insights on how you all are managing that relationship, especially with the institutions that are saying we're not going to compensate you for the learning environment you provide for our students and stuff, like how you kind of manage that, because that sounds really tricky.
Yeah, I'd certainly be interested in others' perspectives on that. And one little tiny variation on that theme is that there are a couple schools that we've had grant money from, and so they've incorporated some funding into that. But there's another school that does give us a stipend, but we're taking more students from them, and they haven't done the other thing that some of the schools have done, which is provide us laptops that the students can use. And I feel like I want to start being a little pushy about saying, we'll only take more of your students if you can help support the hardware that's necessary in this telehealth world. So again, I don't mean to just go on with our detail, but I'm interested if other people have had any comparable questions. Thank you.
Yeah, absolutely. Thanks for sharing. Does anyone else have reflections on their own program or thoughts for Joan?
Hey, Joan, this is Casey Schreiner in Montana. This is actually something we're dealing with right now as well, the compensation piece. Our public institutions, which is essentially our only partner institutions, actually are barred from compensating us. It's just the way our university system's built, and we're in the middle of, we do biennial legislative sessions, and we're in the middle one right now, and the path right now that the legislature in our state has taken is to provide not us as an entity, but the employee who ends up being the preceptor a tax credit as a way to solve it. But we're struggling with how that actually works into our system as well. So I think that's a good flag on a challenge. But yeah, in our state, and we have Turo that's building in our community that we will be working with. That's a private entity, obviously, that has different rules, but everyone else is public in Montana and they're not allowed to compensate. So it's not something they budgeted for or is built into their public budgets. Not that that flag was helpful, but we feel the pain too.
So you don't, Casey, your organization does not compensate people then?
At this point, we don't, and we're kind of just getting into this at a heavier level. And it's one of the things that we literally have an executive team meeting last week that we talked about this, what the appropriate way to build it into our I guess employment profiles or job descriptions for folks in a fair way, because it is more work than what their peers are doing. So that's one of the big pieces for us moving forward. And this is how we do that responsibly, and incentivize those folks to take on that added responsibility, but in a way that we actually can manage ourselves as well.
Yeah, wow. Thank you for sharing that. I had not honestly thought a lot about legislative hurdles as far as restrictions on how public institutions, what they can do to compensate, like kind of outside, clinical partners. that's a real challenge. That seems like something, and our guest from Ohio will have some information on working with states as far as funding. So hopefully we'll have some useful information for you later on.
I'm curious from Casey, is that tax break that's being contemplated, is that meaningful, or is it sort of just a throwaway?
It's a great question. It's like $1,500. So I don't know. I mean, I don't think it's probably meets what a compensation would be, honestly, for the, and I don't, and honestly it hasn't passed yet. So, because the things are still, our budget just is still in the first house of our legislature. So I don't know if I think it's meaningful. I don't know if it's really an incentive for folks.
I think it would be. I mean, ours is $5 per precepted hour. And it's unusual for that to be more than $1,000 in a semester, because it's unusual for it to be more than 200 hours for one preceptor. So 1,500 would sound good to our guys.
Yeah, no, that's good to know, honestly. Yeah. I think if we were front end, if people were on the front end able to get $1,500, that's more enticing than waiting for them tax season to come around and have it knocked off their tax bills, I think is the challenge. It's a little more sophisticated incentive. You got to get there, jump through some hoops in your mind to actually see the value of it. I think when you're doing this work day in and day out, it's deferred gratification, if you will.
Yeah. Well, yeah, thank you for sharing that challenge. And we have just about 2 or 3 more minutes. So if anyone else has something they would like to add.
Hi, this is Susan Willis. I'm in Texas, and we have a relationship for where we train residents with a health system and a relationship with a medical school. Both of them have been very reluctant to say they would compensate on a per trainee basis, but we have been successful with getting both of them to agree to reimburse us for expenses. And so we've gotten some funding to help us with our costs by having them reimburse us for things like medical record, or EMR, licensure fees, purchasing computers, purchasing other kinds of things that they've been willing to put money on the table for and not call it compensation for training.
Yeah, and I wonder if, and it obviously would depend on the specifics for the legislation in those states, or in Montana, in Casey's case, you know, what can be provided and what can't. But yeah, that's an interesting option, as well as kind of covering some other costs or sharing equipment or something. A good example of kind of.
Susan, does that mean contributing towards EMR license fees and computers and such for the students or for staff, or maybe it doesn't matter?
Yeah, I mean, mostly for students, but we have gotten them to pay for some of our staff costs. The medical school it even gave us money for our faculty's medical education expenses. The health system, because we were doing OB residents, paid for an ultrasound machine. So we found it very interesting, the kinds of things that they will say, oh yeah, we could pay for that. But like I said, neither of them would say, yes, we will compensate you or come up with an agreement based on the number of students, number of hours, rotations. It had to be completely separate from calling it a training compensation. But like I said, they've been pretty flexible about us coming up with reimbursement, including, again, the hospital system reimburses us.
Excellent. Well, thank you, yeah, for sharing that. It sounds like there are some potential good options for kind of workarounds, even if the ideal can't necessarily be achieved. And I don't want to delay our guests from presenting, but let's definitely pick up the conversation again at the towards the end of the Learning Collaborative. But if it's all right with everyone, right now we are going to change it up a little bit, and we are going to hear from Dr. Curry Kim, who is a captain in the U.S. Public Health Service and is the senior advisor for the Division of Medicine and Dentistry at the Bureau of Health Workforce. And she's going to present on some of the kind of financial and other support that the Bureau of Health Workforce can offer. And so I will turn it over to her, and she's brought with her several guest speakers or guest subject matter experts. So I will let you introduce them, Dr. Kim.
Great, thank you so much. So it is my pleasure to be here today to provide an overview of the training and development programs administered by the Division of Medicine and Dentistry, DMD, within HRSA's Bureau of Health Workforce, BHW, specifically the programs that community health centers are eligible applicants for or are critical partners of. Next slide. I'll briefly provide an overview of our Bureau, then run through our division's programs that are most relevant to health centers, and conclude with some Q&A time with our subject matter experts. And I'll just introduce them as we go through the relevant sections. Next slide, please. This slide shows HRSA's organizational structure, and you can see that the Bureau of Health Workforce, BHW, is outlined in red. It's one of several bureaus within HRSA, a sister bureau to the Bureau of Primary Healthcare, BIPIC, which many of you may be more familiar with, outlined here in blue. Next slide. BHW improves the health of underserved and vulnerable populations by strengthening the health workforce and connecting skilled professionals to communities in need through the administration of grants, loan programs, and scholarship programs guided by its health workforce research activities. Next slide. In brief, BHW aims to expand access to healthcare, balance the supply of health workers, strive for equitable distribution of the health workforce, and improve the quality of care. Next slide. Within BHW, we have 10 divisions, and we'll now go into reviewing the programs within the Division of Medicine and Dentistry, DMD. Next slide. As mentioned, we have 3 branches in DMD, each of which has training and development programs that include community health centers as grantees or vital partners. Next slide. Within the graduate medical education branch, we have the Teaching Health Center program, which some of you may be familiar with. The Teaching Health Center Graduate Medical Education Program, THCGME, supports primary care, medical, and dental residency programs in outpatient community-based settings, such as FQHCs. As you know, the vast majority of residency programs are funded by the Centers for Medicare and Medicaid, CMS, as payments to hospitals. So the THCGME program is an innovative model of training to fund residencies in ambulatory settings where they are most needed. Eligible medical and dental specialties include family medicine, internal medicine, pediatrics, med-peds, OB-GYN, psychiatry, geriatrics, general dentistry, and pediatric dentistry. We can just stay on this slide. Thanks to the American Rescue Act, we were also able to fund the Teaching Health Center Planning and Development, THCPD program, which supports grantees to establish new accredited public community-based medical and dental residency programs in the same specialties as the THCGME program. So these are startup funds, acknowledging that it takes a significant amount of resources and time to become accredited. We have I'm not sure if they were able to join. Some of our subject matter experts were having trouble with the Zoom link, but hopefully Crystal Waters and Kristen Gordon, our THC project officers and subject matter experts, will be able to answer more questions about THC after this brief presentation. Next slide. The branch also funds a THC Technical Assistance Center, thcgme.org, and you can see a picture of its landing page on the right side of the slide. The center recently just published a THC info sheet, which I can circulate to the organizers, or I can drop it into the chat box if I have that functionality a little bit later. And on the left hand of the slide is a resource that was published by NAC that may be relevant to you if you're interested in potentially becoming a THC, which you can download from the link on the slide. Next slide. While the THC program includes dentistry residency programs, we have other dental training programs as well. Within the oral health branch, we have the pre-doctoral training program in general, pediatric, and public health dentistry and dental hygiene, as well as the postdoctoral training program in general, pediatric, and public health dentistry. Both programs aim to improve oral health, especially for vulnerable, underserved, and rural populations. Eligible entities are those that have accredited dental training programs, which can include community health centers, such as THCs. I am pleased that Jesse Ungard, Acting Chief of the Oral Health Branch, is on this webinar to answer your questions about their dental training programs at the end of this presentation. Next slide. The Medical Training and Geriatrics branch has several programs that community health centers may be eligible for if they meet criteria, such as being accredited to sponsor a medical training program. These include the Primary Care Training and Enhancement, or PCTE program, which actually encompasses several programs, each with its own focus and notice of funding opportunity. PCTE programs aim to strengthen the primary care workforce by supporting enhanced training for primary care clinicians, educators, and researchers in rural and underserved areas. Next on the list is the Geriatrics Workforce Enhancement Program, or GWEP, which aims to improve health outcomes for older adults by developing a healthcare workforce that maximizes patient and family engagement, and by integrating geriatrics and primary care. Among the types of eligible entities are health facilities, such as community health centers. Next, I want to mention the Preventive Medicine Residency Program, which trains physicians in the specialty specifically dedicated to population health. Now, while community health centers are not eligible direct grantees, the most recent NOFO requires a rotation at an FQHC, during which residents are to conduct population health studies or activities to improve patient outcomes in the FQHC's catchment area. Next on the list is the Addiction Medicine Fellowship Program, which aims to increase the number of addiction medicine specialists who work in underserved community-based settings that integrate primary care with behavioral health. Amongst eligible entities for this grant is a consortium that includes a THC, many of which are community health centers, and an addiction medicine or addiction psychiatry fellowship program. Next on the list, the Integrated Substance Use Disorder Training Program, which aims to expand the number of nurse practitioners, physician assistants, health service psychologists, and or social workers trained in mental health and substance use disorder in underserved community-based settings, and integrate primary care and behavioral health. Eligible applicants include THCs, FQHCs, rural health centers, and Indian Health Service administered health centers, and community mental health centers, among others. Finally, I'll mention the Rural Residency Planning and Development Program, which is administered by the Federal Office of Rural Health Policy, or FORP, in conjunction with DMD. This program funds new rural residency programs in the specialties of family medicine, internal medicine, psychiatry, OB-GYN, general surgery, and preventive medicine. The list of eligible entities is broad, but also includes community health centers. And again, this is a planning and development program. So again, providing startup funds for entities interested in developing these training programs. And I think our branch chief, Cindy Harn, chief of the medical training and geriatrics branch, might be having a little bit of difficulty getting onto the webinar. She's been emailing me, but hopefully she might be able to get on in a little bit. Okay, so the last slide, next slide. This is the last content slide anyway. This chart summarizes the difference in HRSA's graduate medical education programs versus other sources of GME funding. While this is geared more to the THC program in particular, aspects of accountability apply to most of DMD's training programs, given HRSA's focus on supporting community-based training and encouraging clinicians to work in medically underserved areas. Next slide. So now that's it from me. We have our some of our branch chiefs, I think, and subject matter experts. If you have further questions about the programs covered here, thank you so much.
Sorry, I couldn't unmute. Thank you, Dr. Kim. And yeah, if anyone has any questions, feel free to raise your hand or put them in the chat. And in the meantime, I guess one question that I had was if people are applying to different funding programs, because I know that HRSA has different programs to support all of these different medical education efforts. Many times, what's kind of what should people expect as far as what HRSA is looking for in general, just in kind of applications, and then working with HRSA to manage the funding for these programs? Are there any kind of insights you can provide into that?
Before I can just generally say that each funding opportunity will have its own criteria, its own requirements, and its own evaluation. So each of these NOFOs will go through an objective review committee, and you know, if you have one training grant, you can have multiple. You know, so there are many community health centers or FQHCs that actually have multiple training grants, even within the same program. Sometimes they can have a couple of grants. So I will see if Cindy is actually on the line. Again, she's our branch chief for the medical training and geriatrics branch, which has a number of programs that I went over. So I don't know if Cindy or Jesse have any further insights.
Hi, good afternoon, everyone. Yeah, I definitely concur with what Dr. Kim mentioned. Each program, when it's competed, will have a notice of funding opportunity. So it's really important to look at some of those, even if it's an old one from a year or two ago. You know, start familiarizing yourself with what those NOFOs look like, what kind of information they ask for. On the dental side, certainly since the ACA passed in 2010, a lot of our dental training programs have emphasized interprofessional training, so training dentists alongside medical students, pharmacy students, other professions. And then there's been a large emphasis on community-based training, right? So making sure future practicing dentists have had rotations out to community sites, whether it's federally qualified health centers, rural health centers, other community-based organizations. We have had other areas that we've emphasized in some of our notice of funding opportunities. We have had cycles where we have asked for additional pediatric competencies to be included in pre-doctoral dental trainees. We've had cycles more recently on the postdoc side where we've really emphasized additional training for serving medically complex patients or patients with special healthcare needs. So it depends on what each individual NOFO is calling for, what you'd have to think about. Do you want to go for that funding opportunity? Do you want to kind of move in that direction for that type of training?
Excellent. And then are there different sites? I know I've been on HRSA's site and looked at the where all of the NOFOs pop up. I guess, is there a way to, say, receive email updates if you're looking for a specific program? So if I'm looking specifically to train dentists, is there a way to get alerts when an oral health specific NOFO pops up?
I mean, you can definitely get updates in general on the HRSA website. So at the bottom of the main page of the HRSA website, I would sign up for the newsletter. It's a weekly, once a week newsletter. And when any notice of funding opportunity comes out across the agency, it would be included in that. And that would certainly include BHW as well. And then the other thing that's a good practice is just to go on grants.gov on a regular basis every week or every couple of weeks and do searches if you have a specific interest in oral health or dental training that way as well.
Excellent, thank you.
So Cindy Harn is, she's on the phone. She wasn't able to get into the Zoom link. Is there a way to unmute her? So she
Yes, let's see.
I believe if Cindy presses *6 on her phone, that'll unmute through to the system.
Hi, this is Cindy Harn. Can you hear me?
Yes.
Are you able to hear me?
Yes.
I would just add that a lot of times we have prospective grantees call and ask us what would be most helpful when they're trying to put together a proposal. And I always refer them to HRSA Find. It's HRSA.data. When you go onto there, you can look at the various grants that have been already funded, and their abstracts are available. The funded abstracts are available for all of our previous and past funded grants. So, for example, if when the next funding opportunity comes up for the Addiction Medicine Fellowship Program, you may want to go to HRSA Find and then, look up for those grants and look at the various abstracts that actually were submitted and awarded. The other thing that I would suggest is that, we tell this in our technical assistance, meetings that we have prior to going to the submission of the applications, that look very carefully at what the purpose of the grant is. And as Dr. Kim said, we also look at the various criteria that is in the grant, is in the funding opportunity. It's very important. Very often, prospective candidates for these grants miss very important pieces of the grant. And so sometimes they're, they are not eligible for the funding. And they, you have to go through the NOFO really from beginning to the end and make sure that you understand what the purpose is, what the objectives are, and then go through the individual criteria. I would just add that.
Yeah, thank you very much. No, that's that makes sense. Definitely important to read what the criteria is and make sure you're eligible. But that's really good to know. You said that's on HRSA.data. Is where you can see the prior funded programs?
Right. I Google HRSA Find, F-I-N-D, and we renamed it here but that's how I always find you. Go to HRSA Find, HRSA Find or HRSA Data. And then you just go in to that application. It's data.hrsa.gov. But HRSA Find is an easier way to finding it. And then you go into the tools. If you go in, there's a radio button. If you go into the tools section, go under Find Grants, put in the name of the grant that you're looking for, and the awarded applicants are there with their contact information as well as their abstracts.
Excellent, thank you. And Helen dug that up and put the link in the chat for everyone, so you can copy that link down. So you'll be able to go look at prior successful grant applications to see what everyone else did and kind of model after the successful applicants. Yeah, excellent, thank you. Okay. Does anyone else have any questions for our guests? And if not, Dr. Kim, thank you so much. And thank you to your team for joining, to everyone, all the subject matter experts, for taking time out of your day, all various department leadership and everything. So we really appreciate having you here. You are welcome to stick around, but I know you have plenty going on. And so don't feel obliged to hang out. But again, I really appreciate the time and knowledge that you've shared and the resources that you put out there. So thank you very much.
Thanks for the opportunity. Bye.
Thank you.
Take care. Okay, everyone, we will now turn it over. Oh, and here's the contacts. And yes, the slide deck will, as before, be posted in our discussion board, so you will have the email contacts here. And so I just wanted to say thank you one more time to our colleagues at HRSA. And now I am going, oh yes, did someone have a question? No, okay. So anyway, I am going to now turn it over to the Ohio Association of Community Health Centers. And we have two guests from OACHC with us today. We have Marie Grady, who is the workforce manager, and Marie manages, implements, and evaluates the association's Ohio Primary Care Workforce Initiative that supports students teaching in the FQHCs. And along with these efforts, she supports the HR professionals with workforce development and working to enhance their workforce. And we also have Kelly Carey, and she is the Director of Policy and Public Affairs. And Kelly is involved in government affairs, public policy, and external relations on behalf of OACHC. So I want to say thank you to both of you for being here, and I will stop my screen share and turn it over to you.
All right, Kelly, I am doing the screen share now. There we go. All right, can you guys see it?
Yes.
Okay, so Kelly, go ahead and take it away. Just tell me when to go next.
All right, thank you, Marie. Good afternoon, everyone. As Alex said, my name is Kelly Carey, and I'm the Director of Policy and Public Affairs for the Ohio Association of Community Health Centers. And my role is to be the face down at the State House here in Ohio. We represent 57 federally qualified health centers or community health centers, which comprises of over 480 sites across the state. And as many of you know, we are federally funded, but here in Ohio, we do have one line item, and it is the Ohio Primary Care Workforce Initiative. But prior to that, since the 1990s, we had this one line item underneath our Department of Health, and it was for uncompensated care or for those that are uninsured. Well, then you fast forward to 2014, and the Governor Kasich at the time, and the General Assembly went ahead and expanded Medicaid, which allowed more coverage for the patients in Ohio. And when they did that, they came to the association and they said, okay, so they thought we fixed your number one need, which is coverage. What is your next biggest need or priority? And sadly, as we sit here in 2023, it is still the same. And I'm sure all of you are feeling it, and it's workforce. And so the association worked with the department and with the General Assembly to create the Primary Care Workforce Initiative. And Marie is the driver, the owner, the subject matter expert of it. So she'll get into the weeds of the actual program. But my job is to maintain that line item in the budget. I know somebody mentioned in another state they are in their budget season, and so are we in Ohio. We have a biennium budget, so we do it every 2 years. And we are very lucky here in Ohio that we have bipartisan support for our community health centers. However, the department likes to zero us out in the budget in order to make cuts that the governor has issued. And so our job is to go to the General Assembly with our partners at the schools and the primary care associations and ask for that funding back. Well, this year we are very pleased to see that the governor, understanding workforce is such a big priority, did include $5.4 million over the biennium. This is the same funding that we received since 2015, but we are not asking for an increase. We're just keeping it going and making sure that it's successful. Next slide, Marie. Well, I'll keep going. She can have the slides catch up to me. So as I said, this legislation, it is very plain and simple. It is one line item under the Department of Health, and then underneath that is some temp law language that basically just says what the funding can be used for. Here in Ohio, we do not have any rules around it. We do not have any legislative language besides just describing the program. So a lot of the work happens behind the scenes with OACHC working with the Department of Health directly via contracts, which I know that Marie will get into the weeds on all those areas. But our goal was to try to fix the primary care workforce shortage. As many of you have probably seen, we need more providers, especially those in primary care. So this program was developed to hopefully encourage primary care docs not only to stay in Ohio, but to serve in our underserved areas. Understanding that community health centers are in medically underserved areas, a lot of times it's very hard to recruit providers. We can't compete with big hospital systems with their sign-on bonuses or their salaries. And then the areas that we are located, sometimes it's tough to recruit providers to want to live or to locate their families there. So we are very hopeful that this program, which we have seen the results, is successful in getting people into those areas and having them stay in Ohio, because we're selfish like that right now. But no, it's a great program, and I believe now I will turn it over to Marie to dive more into the details.
Thank you, Kelly. I can't get this Zoom together still, you know. So thank you. So thank you, Kelly, and presenting on the big picture of OPCWI. And she works hard, her and Julie, diligently at the state, you know, trying to maintain our funds and just advocate for us and FQHCs in general. So thank you, Kelly. So the Ohio Primary Workforce Initiative. So the goals behind the program are to expose students to community-based settings with underserved populations that they will not get in regular clinical rotations. Usually it's at private practices or hospitals, so they receive unique experiences when they come to the FQHCs. They experience interprofessional team care practice. We push for integration and integrated care, and for our students to see that. So we want them to see how they can do a warm handoff to the dentist or to the pharmacist and the behavioral health, and to talk about the patient's issues and discuss how they can further have preventative care or solve the problems. So we push that heavily with our FQHCs, especially for student experiences. So they experience high quality educational experiences at the FQHCs. All of our FQHCs are from all medical schools from all over the world that have received quality education, high quality education. And we want the students that come there to see that and be exposed to that, and not just in regular private practice. So the outcome is to increase primary care capacity. So we know we have a shortage of primary care providers in FQHC. So the goal of this program is to increase the primary care providers in the FQHC settings for medical, PAs, APRNs, dental, and behavioral health. So we want to retain more health professionals and graduates in Ohio. So our program is Ohio program. So we're hoping that these students who go to school in Ohio want to graduate and then work in one of the FQHCs, especially with all the great benefits. You're helping the community. Sometimes they cannot help themselves. You have national and state loan repayment, and just in general, I think the overall satisfaction of helping people, again, like I said, who cannot help themselves. And then also we encourage more graduates to be Medicaid providers. So we do track a lot of these. One of those, tracking the Medicaid providers, we do track that in our outcomes, and I'll touch on it in a few minutes. So keep your thoughts on that. So program measures. So we collect a lot of program measures and there's student demographics that we collect from the students because we have to track these students over time. So there's a lot of information that we need in order to track these students. So these students come from all over the nation. So we track, when we track our outcomes and we collect these process measures, we're looking to see if the students are working in the FQHC, if they're working in a medically underserved area, and if they are accepting patients that are on Medicaid. And in order to track all of that information, we need all of these process measures to track the students. And also the last column, the last bullet is number of students precepted by discipline and health profession school. So that process has to do with reporting and reimbursement to the FQHCs, and I'll touch on that throughout the slides as well. And if you have any questions throughout the presentation, please feel free to stop me. Alex, if there's anything in the chat, and Michelle, you can stop me and I'll ask any questions.
Absolutely, thank you.
So outcome measures. So we track a lot of outcome measures. So one of them is, did the precepted student stay in Ohio? So I do have a few of those measures to share with you today. So did the student stay in Ohio? So it's kind of hard to track students that are in residency. So we try to reach out to a lot of the schools to see if they collect alumni information or if they would like to share with us their residency information. We only had a few schools participate, but we want to track, are they in primary care in residency? Are they at an FQHC in residency? So we do want to track that even though they're in residence. We know that it may be a little bit difficult at times to track medical students because they're in our health centers from Med 1 to Med 4. So they're there for a long period of time, but we do try to track them while they're in residency. And we have recently contracted with George Washington University to help us support us with these outcomes because they have a larger data sets that they utilize, and they have the bigger picture, more resources, especially than we do. So we're excited to see what those outcomes are going to be. And we're going to continue to work with George Washington University as well. So the next one is, did the precepted students enter primary care practice? So to date, we have 661 participants that were hired by Ohio FQHCs, and we're excited about that number. So the goal, again, of our program is to teach the students, recruit the students, and retain the students. So we're happy to see that number. And then the next one is, does the precepted student accept Medicaid or uninsured patients in their practice? So currently we have 1,164 former OPCWI participants that have billed Medicaid for healthcare services in years 1 through 6. And that could be an underestimate of some of the providers, because some of the providers can't bill through Medicaid, so they have to bill under another provider. But that's just a guesstimate of where our numbers are today. So let me get back to my PowerPoint. There you go. Okay. All right, so participation requirements. So in order to participate in OPCWI, the health center has to have PCMH recognition, or there's other criteria of recognitions that we do consider. And if they are not PCMH or have the other accreditations, for example, CPC or NCQA or AAHC, I believe I said it right. They have the opportunity to submit an application a year or two into the program, and then if not, then they would have to drop off, because we want the students to experience what a patient-centered medical home is. So that is one of our biggest criteria for our program. We also encourage the providers to obtain teaching faculty or volunteer faculty appointments as an incentive for teaching at the FQHCs. So with those appointments, if you guys aren't familiar with it, they can obtain CMEs or up-to-date library access, discount on football tickets. So there's different things that can go along with teaching. And we also encourage our health centers to be more involved with the schools and invite the schools in when they're having community outings or community events, just to show a presence in the collaboration between the FQHC and schools. So we just don't want them to send their students there, and that's a regular clinical rotation, because we know our community rotations aren't just regular rotations. They're a different type of different type of gift that they're going into, something they may not be used to, but some of the schools just aren't familiar with FQHCs as well. So we try to have this FQHCs invite the schools into their area so they can just be more familiar and be more like a family in collaboration, and they can see the community at wide as well. Then the next one is participate in preceptor training activities. So every year we provide preceptor development opportunities for our preceptors. We invite the students in the school as well to participate because we want to continue that collaboration and learning. The next one is reporting. So this is a big piece. And I know you guys were talking about, others were talking about funding. So every quarter our FQHC submit to me a clinical rotation report that has the student demographic information as well as other reporting data. So they have to report in order to get reimbursed. The quarterly reporting has to include the dates, the end and start date of the student's clinical rotation, as well as their hours. And then from that information, we have a formula built into our spreadsheets, and it calculates the amount they will get paid for that student. So our students, and it will show further in the presentation, our students, we are billing per clinical hour. So for example, if you have a behavioral health student that is there for 670 hours, there's a formula in there times 15, and then that's the amount that the health center will get. And the health centers get reimbursed quarterly for clinical teaching. And then some of the health centers do incentivize the providers for teaching. Some do, some don't. Some of them use it towards preceptor development training or different costs that go along with teaching. So for example, in the past, health centers have used it to purchase licenses, to purchase laptops or iPads, or to use for a student area in their FQHC, so students can have their privacy for when it's time to chart or do different things like that. So they have the opportunity to have their own space. So our FQHCs, once they get the money, they can do with the money what they please, except for, there's guidelines for using state funding, but they, a lot of them use it in different ways. So, really excited. A few of the health centers do incentivize the preceptors, and they give them guidelines for receiving incentives. So I like they hold them accountable for different things that are due for a program. And that way they're not the one person in charge of completing different data or student evaluations that we have. So they enjoy getting their incentives. And if students don't complete the required information for the program, the preceptors will call and say, hey, the student, did they do this? So they're on it too, as well as the point of contacts at the FQHCs. Is there any questions? I know I'm going I'm not trying to go at a slower speed because I want to answer any questions if there are any. So are there any questions at this time? Nope. Okay. All right, I'll keep going. So if you guys just feel free to shout out a question. So student participation. So Alex, can you guys still see my screen?
Yes.
Okay, cool. Okay, student participation. So in order for our FQHC to report a student, there has to be an Ohio connection, either Ohio school or the student that is attending an out-of-state school. Their state of legal residency needs to be Ohio. Since we have state funds, we really can't utilize state funds for outside students that don't live in Ohio. So those are the two criteria in order for a health center to report a student. The next one is reimbursement. So each health center can earn up to $50,000 each year for clinical teaching. And then after that, after their $50,000 earnings, their money goes into a pool of money until the end of the year, because we don't want to exhaust our funds by spending every last dime, maybe our first quarter, because some health centers teach robustly and their first reimbursement may be potentially $80,000. So if they had that every single quarter, it would exhaust our funds. So we put a cap in place so everybody can reach that cap. And then at the end of the year, if we have funds left over, we have a formula in place where we pay everyone a percentage of their teaching from what funds we have left over from our quarterly reimbursements. So I know that was kind of big and heavy, but we have to have we feel the cap is in place to just make sure everybody is able to receive funds equally. And then at the end of the year, if we have funds left over, we'll reimburse those people who are over the 50,000 soft cap with our formula. The next one is, I think I touched on that. So we do require students to complete a student evaluation. So quarterly, we had to put in place that in order to receive any type of reimbursement quarterly, the FQHCs had to have 50% of their student evaluations submitted, because we weren't really hearing about how teaching was going in the FQHCs. And we can't improve teaching or just praise your teaching if we don't know how it's going from the students. So every quarter, the students are required to complete a student evaluation, and that comes directly to me, and it's anonymous. And from that evaluation, if they have 50% completed from their submitted quarterly report. So if they had 10 students who rotated, 5 need to have it complete. We want all 10, but at least 5 need to have a student evaluation complete in order to receive your reimbursement for that quarter. Now for the year, in order to receive your over soft cap earnings, you have to have 70% of your student evaluations for the year completed. And that's just, we really just want to monitor the program, and we can't monitor the program if the students aren't completing the evaluations. And also from the evaluations, we share them with all of our FQHCs. We share them with external people as well. We share them with ODH especially. And we also, if there's any problems, we want to be able to address them as well. So any problems that we have had in the past, as soon as we reach out to the FQHC, they're already on it. So they know it before we knew it. So they addressed the issue, and that made us feel good because they already knew about the concern. Any questions before I move forward? I know that was a big, heavy slide.
And apologies, I think I missed it when you said it. Do you, is there like a stipend or something for preceptors?
So preceptors, so FQHC has the capability to incentivize their preceptors, but it's by each FQHC. So whatever they decide to do, that is okay. We are okay with them if they want to incentivize them. Some of them do it quarterly, some of them do it yearly. And then as well as we have a few PA schools in Ohio that reimburse on top of us. They reimburse the preceptors for teaching up to $1,000, I think, per semester. Because they're in high need of preceptors for PA. So we do promote PA placements in our FQHCs, and we're pushing more on our FQHCs because a lot of them don't take them because they're just not educated in what PAs can do. So we continue that education process with the PAs on a regular basis. And if we have particular students, we'll share with the FQHCs, but we're continually educating in their scope of practice and how it's the same as NPs, because a lot of FQHCs just don't know. And so we just try to educate them.
Excellent, thank you.
All right, did the next slide go? Okay, cool. So this is our OPCWI eligible student rotations reimbursement rate. So like I had stated, that we pay per clinical hour. So Med 1 and 2 is $27 per clinical hour. Med 3 and 4 is $29 per clinical hour. Dental students, D4 students are or 22 per clinical hour, as well as advanced practice nursing and PA students. And the behavioral health is $15 per clinical hour. And these are quarterly payments are calculated using the clinical rotations hours reported quarterly. And once the health centers send their reports to me, I put a report together for the Ohio Department of Health, and then that goes to them. They review the report, they approve the report, and then reimbursements come to us, and then we reimburse the health centers. Next one, what students have to say. So the students have so many amazing things to say. And we would love to capture all the positive comments, but sometimes it's hard. So I'll just touch on one really quick. One student said, I really love the variety that primary care presents. It was also great to learn how each member plays an integral role in patient care, from providers to the RN coordinators to the BH team. And I'm going to include in here the quality team at the FQHCs also play a huge role, because some of those team members train the students on their EHR learning. So one time we had a meeting with our FQHCs during COVID Zoom, and it was about 10 staff and providers on the call. And it was amazing to see, because we got to see how each of them play a different part of the student rotation, from the precepting to the orientation to the training of the EHR, and just other things as well. So community health workers, social workers. So it was good to see everybody was on the call and everybody had a role to play in student rotations. The next one. So a few years ago, we put in place the Preceptor of the Year Award, because we felt like we needed to recognize the preceptors outwardly and loudly, and just put them on blast all over the state of Ohio. So every year we have had a Preceptor Year, the Year Award, and last year we decided to rename it the Theodore E. Winslow, MD, OPCWI OPCWI Preceptor of the Year Award. And this is because Dr. Winslow had such an integral role, an important role in putting OPCWI together, and also his passion for student teaching. And we just thought it was very fitting of him and his leadership is to put the award of the program he developed, and it was his baby, and named after him. So we have had two providers, Preceptor of the Year so far. So 2021, it was Courtney Levine, and she is a dentist at Community Health Services. And then in 2022, we had Dr. David Cola, MD, and he is with Life Care Family Health and Dental Center. So, and this Preceptor of the Year Award, the whole entire FQHC has the opportunity to nominate a provider, and then we just go through the nominations, and then we choose a Preceptor of the Year, and we go to them and present the award to them as well. And then we present the award at our annual conferences too. And then the next one is a snapshot of OPCWI years 1 through 7. So far we have precepted over 6,000 students. They have completed over 700 student clinical rotation hours. 49 community health centers have participated throughout Ohio. 709 OPCWI participants were higher, but that number, I do have to change that number, so I apologize for that. But it's 661, and then 132 health professional programs, 98 schools, and then a 4.5 out of 5 student experience was completed for the student evaluations from years 1 through 6. So with the 132 health profession programs, we may have 4 different programs within a university. So for example, OSU has dental, social work, nurse practitioner, medical. They have so many different programs. So we potentially could have a number of different programs within the universities. And then that's it. So thank you. Any questions? And I do apologize. Alex, I will adjust that last slide and send it to you. So for an update.
Okay. Yeah, no worries.
Cool.
Yeah, thank you very much.
Yeah,
And
you're welcome.
let's see. Oh, yes. And in the chat, Ashley asked if we can email the slides, and the slides will be part of the deck that we put up, the PDF in the group discussion as well. So you'll be able to have access to all of those.
And I will say the funding is always everyone's biggest barrier. And I think now we just have to find creative ways to find funding to support student teaching. So maybe our managed care plans that have foundations, or your Department of Labor's, or go to your state legislators like we did. There's currently a PCA that is trying to do that now. So I think we just have to think creatively and show the need for your FQHCs in your area, that there is a shortage for primary care providers in your FQHCs.
Excellent. And while we're waiting for folks to put questions in the chat, or again, you can raise your hand with that feature if you prefer. But I guess one of my questions is, what are some of the, if someone was going to be working with state funding and trying to do that, do you have any kind of general advice for managing that kind of relationship? Because like working with a state government, or I think in your case, the funding is kind of through the state health department, right? Is probably a little bit different than building a partnership with, say, like a university.
Kelly, me, yeah.
So I'll talk on the legislative piece of it. Marie can talk about the Department of Health. As far as legislatively, it has really hit home with Ohio that workforce is such a huge need, and that this is a pipeline initiative. And I think that is something that's happening across the nation right now with workforce. So in my opinion, it was it was a lot easier this go around than previous budgets when Ohio was having to do some cuts. But it's all about showing your return on investment. So that snapshot that Marie had at the very end of the PowerPoint is our leave behind, if you will, for legislators to show that this is how many, of your constituents and your areas that are being hired on. And at a time when we need that, it has really struck gold with the legislature. Marie can talk about the department.
And then with us in ODH, I know think you said schools, Alex. So we have a contract with ODH, and then we have a separate contract with our FQHCs, and then our FQHCs have a separate contract with the schools. So we're kind of the middleman. We put the schools in contact with the FQHCs, and then we just step back until we're called to step in. So we do request that the schools get a affiliation agreement, especially if it touches on malpractice and liability insurance, because that's the biggest piece in a contract that you need, especially with student rotations, students that are coming in to your health center that aren't providers, and they're seeing patients. And there's just a lot of different things that they're going to see and hear that they just need things in place to cover the health center, cover the school, cover students. So that is how that works. And quarterly, we do meet with ODH to go over our submitted report. And then it's kind of cut and dry. We submit the reports. They submit the reports to me, we submit a report to ODH, and then ODH in return reimburses us for teaching, and then we reimburse the health centers for teaching. So we do manage all of those funds, and then quarterly we just reimburse the health centers, and then at the end of the year, if they're available for those funds after their 50,000, they're able to get those as well, as long as they fit all the criterias. I hope I answered. Did I answer your question correctly?
Yeah.
Okay.
Yeah, I mean, I think it sounds like if you're trying to say you're a health center, you're trying to partner with your PCA in your state to kind of get some changes to help make that process of taking on learners easier, or get reimbursements or whatever, that yeah, really showing that money that needs to be spent by the state or through a educational institution or whatever, is, like you said, that return on investment. Like, what are you getting for that?
Right. And you have to think creatively, you have to think outside the box, you have to get buy-in from your FQHCs, especially your C-suite folks at your FQHCs, because if they don't see a vision in teaching, you're not really going to go anywhere. So I think it's buy-in and just creative ways to look for funding. I know it is hard, and we have a great advantage with our state, but our providers work really hard and really love to teach our students. I mean, they love it. We don't have anybody that has said, I just don't want to teach, but the reviews that we get from the students are just amazing. We have some students that never even heard of a FQHC, didn't even want to go, didn't want to go to the area, was against it, was like, no. And then to hear their eval, it's like, this was the best experience I had throughout my whole health profession career as a student. And for us to hear that, from the negative to the positive, and how they just changed their mindset, that especially that everybody is not like me, and some people are poor, You know, people really don't think people are actually poor until, or there's a need until they actually see it. So, so they see the needs of people out there in the different communities that just, you know, it just, some people are just need support, and that's okay. And doesn't mean that they're better or less of a person than you are. It's just different circumstances in different people's lives. And that's what our FQHCs are there to do.
Excellent. Well, thank you so much. I really appreciate it. And I will give some time in case anyone else has any questions to add in there. But I want to thank both of you, Marie and Kelly, for joining us today and kind of sharing your experience and perspective and everything. Because I think that is really valuable to see that there are opportunities kind of partnering with states and everything. So.
Yes, and feel free to contact us. We can help you, support you, guide you on your way. We believe in collaborating with our PCAs and working together as one. There's no need in working separate and having different mindsets, and we just all can be the same. Not the same, but different. Different, but the same. All right, thank you guys. Have a great day.
Thank you so much. You as well.
Bye-bye.
All right, everyone. So just like last time, we will have more coursework related to this on the discussion board. And some of this will be kind of constructing cost assessments that you may need to get some information depending on what department you're in at your health center from your HR or accounting folks. But hopefully this will help with assessing kind of facilities and staff costs. And that kind of goes into what Marie and Kelly spoke about with looking at return on investment, right? Because that's part of figuring out return is kind of what's your initial cost, and then what are you getting out of it? So, so if you see a big increase in your workforce down the road, what was the initial cost to get there? And that shows you what your return is. So hopefully that coursework will be useful for you. And then next meeting will be April 18th, and we will be looking at HPEP programs focused on allied health and support staff. So medical assistants, dental assistants, community health workers, those kinds of staff that can fill a lot of staffing roles and can be bridges into various roles within the health center. And then I believe there'll be an evaluation popping up on the screen here. Excellent. If you don't mind, just take the 30 seconds or so to fill that out for us. We really appreciate it. And then, as always, we have tons of resources available on the STAR Center website. And you can sign up for our newsletter if you don't already have that. And then feel free to reach out to us with any issues or questions. And if anyone has any problems accessing the discussion board to get those resources, just let me know. I will post the slides from today in PDF format. So you'll be able to click on all the links and everything from that. And then also Dr. Kim from HRSA sent another document. So I will post that up as well that talks about the Teaching Health Center GME program and some of the opportunities HRSA has for funding around that. So I'll post that document up there as well. And otherwise, I think we are going to wrap up basically right on time today. Let's see. Yes. So let's see, Alexandra, you need the link to the discussion board.
Yes, please.
Okay. Excellent. I will get that sent to you as soon as we log off here. Okay. Excellent. And unless anyone else has any other questions, I will let you all get back to your afternoons. Thank you very much, and we'll see you in April.